Welcome, everyone. This is Cindy Lowen. I'm a dietitian and medical affairs manager at Nestle Health Science. I will be moderating today's presentation entitled Multidisciplinary Approach to the Nutritional Management of the Mechanically Ventilated COVID-19 Patient. I'm very pleased to introduce our speakers for today's program. Dr. Subin Jain is a pulmonologist in the Louisville area and is affiliated with both community and academic medical centers in the area. He received his medical degree from the Medical College in New Delhi, followed by a medical internship at Long Island Jewish Medical Center in New York, medical residency at the University of Connecticut, and pulmonary critical care and sleep medicine residency at Baylor College in Houston, Texas. Dr. Jain has practiced medicine for over 20 years. Before joining a private medical practice, Dr. Jain served as assistant professor of pulmonary critical care medicine at the University of Louisville for 6 years, where he remains on faculty. Dr. Jain specializes and is board certified in internal medicine, critical care medicine, pulmonary medicine, and sleep medicine. He provides leadership in the medical care of patients with COVID-19 in the city of Louisville, Kentucky. Kara Davis is a critical care dietitian at a 500-bed hospital in Louisville, Kentucky. She completed her bachelor's and master's degrees of science at Ball State University in Muncie, Indiana. Over her 25-year career, she has practiced in multiple areas of critical care, including neuro, medical, surgical, and cardiac, as well as oncology, coronary care, and the NICU. She spearheaded the CoreTrack Super User Program at her hospital and has been placing small bowel feeding tubes in patients for the past 10 years. She also has been providing advanced small bowel feeding tube placement training to other medical care practitioners across the country for 8 years. Kara is currently the dietitian for the ICU that is dedicated to COVID-19 patient care. Kirsten Gooch is a registered nurse at a 500-bed community hospital in Louisville who completed her nursing training at the University of California, Irvine. Her specialties include ICU charge nurse, rapid response team, stroke committee, and progressive mobility project team leader for the ICU and CCU. Trained by Kara, Kirsten is a CoreTrack super user and one of 5 critical care nurses trained to place small bowel feeding tubes in her facility. Kirsten is on the medical team caring for the COVID-19 patients in her hospital. Now it is my pleasure to present Dr. Jain and the multidisciplinary team to relate real-life application and translation of critical care nutrition guidelines into medical management of the critically ill COVID-19 patient. Dr. Jain?
Thank you. This is Subin Jain. I'm a community pulmonologist in Louisville, Kentucky, and thank you to Nestle for the invitation to this webinar. We'll get moving right along with the objectives of our talk, which are to talk about mechanically ventilated COVID-19 patients with a focus on initiation of feeding and the challenges that these patients face during their stay in the critical care units. Kara is going to explain the role of the registered dietitian in nutritional assessment, tube placement, and initiation of feeding of the mechanically ventilated COVID-19 patients. And Kirsten is going to talk about the key responsibilities of the RN in this very special patient population. So we'll start the talk with a poll. We would like to know what is the clinical background of our audience, and if you'll please respond on your screens. So it looks like the majority of our audience is registered dietitians and a few registered RNs. So the first slide here talks about or demonstrates to you the extent of this problem in Wuhan province, which is where this pandemic initiated. This pandemic seems unending at this point, but it is worthwhile to remember that the first case of unusual pneumonia was discovered around Christmas 2019 in the Wuhan province. But this disease onset is now thought to have been present since the early part of December. the Hunan seafood market was closed in early January, and the Wuhan province itself was shut down near the end of January. But you can see by the gray bars that the curve kept on rising right up to the point and until just after the Wuhan city shutdown. As you look further down on your screen with the yellow bars, the clinical diagnosis of this disease progressed for the 2 weeks after, which is consistent with the incubation period of this disease. The US data suggests a steady increase in the caseload in our population. The disease was pretty silent until the middle of March when the cases started skyrocketing. And this data is correct from the Johns Hopkins University website up until May the 14th. Looking at the CDC website yesterday, we now have 1.5 million cases reported in the United States with approximately 91,000 deaths. This is a pie chart showing that the major centers affected by this disease have been the large city centers where populations are clustered close together, such as New York, New Jersey, Illinois, Massachusetts. Our Kentucky data itself is given in this table here, and we've, as of May 14th, had 7,200 confirmed cases and 328 deaths. We were one of the states that initiated lockdown relatively early, and we have been able to keep the case surge to a minimum and have been able to manage these in our critical care units as a consequence. This is, again, data true as of May the 14th. The number of cases reported every day changes, and particularly on May the 14th, there were 371 cases reported. I think this was the maximum reported in the last 3 weeks at least. But we are expecting that the caseload will start to increase again once the lockdown starts to go away. And I think we'll see this across the country. So this problem has by no means gone away and is going to be with us for the near future. So this slide shows you that the incubation period of this disease is a median of 5 days, but can be as long as 10 to 14 days. Patients are completely asymptomatic during this period. However, they do carry the infection and can infect other individuals during this period, which is one of the reasons it is thought this pandemic has spread so widely and affected such a large segment of the world population. The onset of symptoms is typical viral symptoms of fever, cough, fatigue, myalgias. GI symptoms can be a prominent manifestation of disease, including anorexia and diarrhea. Most of the patients, thankfully, have mild symptoms only, and 80% of the patients are going to get better without any major illness or requirement for hospitalization. Dyspnea, which is a more serious complication, does occur in about 40% of the symptomatic patients. And of this patient population, again, severe illness occurs in 14 to 19% of patients requiring hospitalization, and 5% of these can end up in the intensive care units. Admission to the intensive care unit is no simple matter for these patients. This is data from a collection of 9 hospitals in Seattle. It's a snapshot of 24 patients who were admitted to intensive care units in the Seattle area. As is demonstrated on this graph, 75% of those patients required mechanical ventilation. That's the red bar. And 49% of the patients had a fatality resulting from the COVID-19 infection. As of March 23, the date of publication of this paper, only 5 patients had been successfully discharged from the hospital after admission to the intensive care units. So this disease is fatal in about 49% of patients who admit to the intensive care units. And even in patients who do survive, there are significant comorbidities associated with it. This is a slide of patients who presented to New York area hospitals. These are 12 hospitals with 5,700 patients reported. And a few of the characteristics of COVID-19 infection stand out in this patient population. There is a preponderance of males, 60% versus 40% females. there seems to be an unusual proportion of African American patients. And we've also seen in other publications that Latinos seem to have more severe disease. Comorbidities are very common in patients who get admitted. And these include hypertension, diabetes, coronary artery disease, asthma, COPD, kidney disease, and immunosuppression as a result of HIV or previous organ transplantation. I think we have another poll now, and I think the question to the group is, have you taken care of a COVID-19 patient in the ICU? Please respond on your screens. Great, so it looks like over half the audience have taken care of patients in the ICU. So some of the things we will be talking about in the next few slides are going to be very familiar to a majority of the listening audience. So we'll jump right into our case study here. The patient we are presenting today is a 66-year-old male who works for a large online retailer that shall remain unnamed, with several COVID-19 positive colleagues. He started off with viral symptoms of a cough, runny nose, and sinus congestion about 10 days prior to the date of his admission. 5 days into his disease, he developed a worsening cough with fever up to 105, sweats, body ache, sore throat, something that we see with severe viral infections, including things like influenza, so nothing unusual there. He saw a care provider and was given an azithromycin treatment pack. However, he continued to progress and presented to the emergency room feeling unwell, not having taken much by way of mouth, and with dizziness and lightheadedness that presented as near syncope. This gentleman does have a history of hypertension and of prostate cancer. He did not have any recent travel, but as stated, he had several colleagues who had COVID-19 infection. This patient was dyspneic on presentation. His saturation was 88% on room air, but he quickly improved to 98% with just a little bit of supplemental oxygen through a nasal cannula. His lungs on auscultation were clear on the day of admission with just a few scattered infiltrates on his chest X-ray. The salient labs are as listed below. As you can see, he had mild renal insufficiency with a creatinine of 1.28. His AST, ALT, LT, AST, and LDH were elevated, as is common in these patients with COVID-19 infections. The CRP and ferritin, which are inflammatory markers, were significantly elevated. His white count was 11,300, which is above the normal of 10,000. Lymphopenia seems to be a salient feature of this disease, and his lymphocyte count is lower than normal, which is consistent with the COVID-19 infection. RBP, which stands for the respiratory virus panel, was negative, but that does not look for the COVID-19 infection on this particular respiratory virus panel. The patient was admitted to the floors. He was given fluids and an antibacterial in case some of this was a bacterial infection. As you can see from the chest X-ray at presentation, there are some peripheral patchy infiltrates on the right and on the left. The chest X-ray, you will see in subsequent films, looks progressively worse. So those are the areas you may want to focus on. On day 2, a nutrition consult was called, and the patient was seen to be taking 75% of his oral diet. Of significance, his skin was in good condition with a Brayton score of 20. His swab for COVID-19 came back positive, and an infectious disease consult was called. He was started on hydroxychloroquine, and the ceftriaxone for possible bacterial superinfection was continued. His oxygen requirement started to increase later in the day, and there is an automatic pulmonary consult at our institution once the patient reaches 4 liters of nasal cannula flow. So a pulmonary consult was called. The patient was reported feeling anxious, so was given some alprazolam. I think the important points to note are hydroxychloroquine is a medication that has been proposed for the treatment of COVID-19 infection. Subsequent studies have shown perhaps it is not as effective as was initially thought, and it is no longer part of the protocol at our institution for patients with COVID-19. Also, the oxygenation in these patients tends to drop dramatically and over a very short period of time, and that is why we have instituted a program of early pulmonary consultation to preempt the need for emergencies in the middle of the night to take care of these patients. By day 3, this patient had persistent fevers. He did not report any subjective shortness of breath. He did have a bowel movement, and I reference this because these patients do seem to have some GI difficulties, as we will reference later on in the talk. The subsequent day, by day 4, his oxygen requirements had increased to 15 liters of a high flow cannula, and he had persistent low oxygen saturations. He was clearly working harder to breathe, feeling worse, and he was transferred to the ICU. As you will see from this chest X-ray picture, the patient is now intubated. He has an endotracheal tube at the upper tip of the chest X-ray. He has a central line in place. The patchy infiltrates that you previously saw in the peripheries of the right lung and the left lung are denser and appear larger. There is also the appearance of an infiltrate now in the right upper portion of the lung. So as alluded to, this patient was intubated and placed on mechanical ventilation on day 4, which is day 0 of his ICU stay. We try and cluster all the procedures that we need to do for these patients at one go so as to limit healthcare personnel having to go in and out of the room. An OG tube was placed. This patient also had a little bit of vomiting at the time of his respiratory deterioration. The infectious disease specialist added a special medicine called tocilizumab, which is an anti-IL-6 product, and his hydroxychloroquine was continued. And again, tocilizumab is no longer used in our hospital as part of the COVID-19 protocol, having been shown to be perhaps ineffective and perhaps contributing to a higher risk of significant infections in these patients. The following day, day 2, I guess we'll call it, of this ICU stay, he was requiring 50% oxygen and a PEEP of 10. He was started on norepinephrine, which is a vasopressor. Hemodynamic instability is very common in these patients when they require mechanical ventilation. The vasopressor needs were titrated based on his mean arterial pressure. We started early trophic feeding with an elemental tube feed. We try to minimize the amount of free water he was receiving. This is important in patients who have what is in essence ARDS, acute respiratory distress syndrome, which is what this patient had at this point. He continued to have increasing oxygen requirements, persistent fevers. Some doxycycline was added for possibly positive blood cultures, which could have been a contaminant, but as a matter of precaution. He unfortunately continued to worsen, requiring 100% oxygen by day 4 of ICU stay, with his PEEP requirements being at 14, and a proning protocol was initiated. As I'm sure all of you or most of you are familiar with, proning requires turning the patient onto his abdomen and face, so essentially flipping the patient upside down. This is thought to benefit oxygenation by improving blood supply to aerated portions of the lungs. It does require a lot of personnel. If it is done manually, up to 4 to 5 healthcare personnel may be required to turn the patient every few hours. At our institution, proning is performed using a specialized bed. One of the brand names is Rotoprone, and we use that bed quite frequently in COVID-19 patients who develop worsening oxygenation. However, proning does have some drawbacks. It is extremely anxiety-inducing, as you can imagine, for the patient to be flipped upside down, essentially. Heavy amounts of sedation are required, and propofol as a sedative was used liberally in this patient. And as a consequence, his tube feed requirements were reduced. As you can see from the slide, perhaps his infiltrates are getting steadily worse. He has his endotracheal tube. He has a feeding tube in place now. I want you to look at his endotracheal tube and see where it is sitting. This is the tip of his endotracheal tube where my mouse is. And if you look on the next slide, his endotracheal tube has migrated upwards. Now this happens with endotracheal tubes as well as with feeding tubes in patients on the rotoprone bed or whenever they are being manually proned, and that's something we have to be very cautious about. So on day 9, there was concern that this patient had a pullback of his orogastric tube, and he had some increased residuals. So the following day, a post-pyloric tube was placed. His endotracheal tube was advanced overnight, as you saw that migrated upwards as well. This patient as of day 3 of hospital admission had no bowel movements thus far. So this is 7 days into his hospital stay, no bowel movements. By day 11, he did start showing some improvement. The proning protocol was discontinued. At this point, his propofol requirement was quite substantial, and the propofol was now providing 726 of his daily kilocalorie requirement. As you can again see from the notes here regarding mucosal injury, skin issues are a big problem with patients on the rhodoprone bed. And this patient developed mucosal injury to his upper and lower lips and to his left cheek. Fluid retention occurs despite our best efforts to limit fluid intake in these patients. As you can see from this slide, this patient has an injury to his upper lip. This picture on the right bottom demonstrates an edematous fluid blister and edema on the feet. And this is an injury on his left cheek as a result of laying up against the bed and being upside down for 4 days or so. His course after proning was discontinued was not completely smooth, and he did have some difficulties with ventilation. His thick secretions commonly occur in these patients, but we were able to avoid further proning by vigorous suctioning of this patient. He did finally have a bowel movement 11 days after his previous bowel movement. Constipation is a problem with several of these patients, as they require narcotics for sedation as well. We were able to start weaning some of his propofol. As he started to wake up, he demonstrated some ICU delirium requiring quetiapine. His blood pressure was finally able to tolerate some diuretics, furosemide for edema. The hypercoagulable state is a big problem in patients with COVID-19. And this picture demonstrates to you a clot sitting inside the common femoral vein. The picture on the right shows that this vein is not compressible, and this clot is keeping this vein from being compressed by the technician. So this patient was, next slide please, started on anticoagulation. This is day 16 now of hospital stay and day 12 of ICU stay. The infiltrates are starting to improve. This patient is still intubated. This is a snapshot of his laboratory data during hospital stay, and I'll point out the important laboratory values. You will see that the ALT rose from 47 to a peak of 259 before it finally started to go down. Similarly with the AST, the ferritin, which is an inflammatory marker, went all the way up to 663 on this patient. The D-dimer, which is a marker of perhaps a tendency to have thromboembolic disease, was extremely high and remained high until we initiated effective anticoagulation. When you look at the CBC, this patient demonstrated lymphopenia with only 4%, 6% lymphocyte count, which gradually improved later on in his disease process. So on day 16, we were able to successfully extubate the patient. It is important to do what is called a leak test, because these patients have required ventilation for a substantial length of time. This patient luckily escaped with just 12 days of being on a ventilator. Several patients can require up to 30 days or more of ventilation. Full anticoagulation was added, as I noted, because of the common femoral vein clot. Due to persistent anxiety, we used quetiapine to try and limit the use of sedatives and narcotics. The patient had further bowel movements with the assistance of laxatives. His tube feeds were changed the next day to a standard formula. Some fiber was added. He continued to improve and was transferred out of the intensive care unit, finally passing a speech evaluation so as to be able to take a modified consistency diet. As his delirium continued to improve and his oxygenation got better, he started working with physical therapy, and his repeat COVID test came back negative. We were therefore able to transfer him to an acute rehab setting in the hospital, where he was treated for critical illness myopathy. And finally, he was able to discharge home on day 40. So this is the final X-ray during hospitalization, and you can see the infiltrates are starting to disappear. I'm going to hand the talk over now to Kara, who's going to talk about some of the nutritional issues that arose with this patient and generally do in patients with COVID-19 infections.
Thank you, Dr. Jain. I'm really excited to talk with everybody today. I'm going to review more of the COVID case study, discussing specifically the decisions we made on the type of feeding tubes we had, the type of formula, and the tolerance issues. I do have a financial disclosure as a trainer for the Avanos company. So I'm sure this slide is a bit of a review for most of you, but I'd like to quickly review the enteral nutrition care pathway for critical illness. First, we do a very thorough nutrition assessment, which helps us determine the severity of illness, which really drives all the decisions we make on our assessment. Helps us decide what enteral access we have, the energy and protein needs we have. All of this helps determine the appropriate formula, the quantity or rate we're going to provide. It's just very important. I want to stress how you need to know the whole picture of a patient when they're in the critical care unit. The Aspen Critical Care Guidelines are also very important tools for us to use. They help guide us as we make those decisions on the enteral nutrition care pathway. I find them very helpful, but sometimes with the COVID patients, they didn't always fit into the parameters that were outlined in the guidelines. So on this slide, I put a few of the guidelines that are specific to the case study and how we chose our tube, the feeding formulas, and tolerance. Okay, so to the case study, let's just review the nutrition portion here. I'll try not to duplicate a lot of what Dr. Jane talked about. So he was admitted early on in our exposure to the COVID pandemic. He was one of our first patients that we treated with the COVID-19. So he triggered an RD assessment from a HIT MST score of 2, poor PO and weight loss. He was eating 50 to 75, 100% of his meals, didn't have any complaints of poor appetite at the time, so there was no intervention at that time. By day 2 of admission, as he talked, he was transferred to the ICU, and our enteral nutrition pathway begins. We did get a more accurate weight once he came to the ICU, and we followed the critical care guidelines from Aspen, and we used 20 to 25 calories per kilogram and 1.2 to 2.0 grams per kilogram of protein. The goal for starting nutrition support is 24 to 36 hours from admission to the ICU or within 12 hours of intubation. Based on him vomiting at intubation, no, we could not start our nutrition support. And he also had a fever of 103. His inflammatory markers were rising, and so were his LFTs. The next day, he had minimal output from his OG, so we decided to proceed with enteral feeds. But due to further emesis, we started with a trophic feed, and we were checking gastric residual volumes. Also, because of the inflammatory state and being on pressors, we chose the peptide-based formula with omega-3 fatty acids. After 24 hours, he tolerated the feeds, and we advanced them to 20 cc's an hour a day to a goal of 60. Again, we are proceeding a little more cautiously here at this time due to the newness and unstable nature of the COVID-19 patient. And at this time, he still had not had a bowel movement, and we added laxatives. So here's another polling question. Are you proning your COVID-19 patient? So 86% are. That's awesome. So back to our patient, our case study. The weekend happens, day 7 and 8. He has some gastric residual volumes up to about 150, but that's not that big of a deal, right? Our policy is typically not holding 2 feedings unless they are about 400 or 500 cc's of residual. So we kept the 2 feedings at goal. He still hasn't had a bowel movement. Dr. Jane described he did decline further, and this is when our proning started to help improve ventilation. The overfeeding and not meeting protein needs were my concern, and we considered advancing his tube to the small bowel, but because of cluster care and preserving PPE, we chose to leave it in the stomach. We did lower his tube feeding to 50 cc's an hour. So 2 days later, on day 10, the patient had tube feedings rolling out of his mouth. The gastric residual volumes were 400. He still hasn't had a bowel movement. He has hypoactive bowel sounds, and his propofol is now providing over 700 calories. I was reconsulted for a small bowel feeding tube placement. So we pulled the OG, placed the nasoduodenal feeding tube into the first portion of the small bowel. He had very poor gastric motility, and that impacted my ability to get the tube any further. I was very hopeful that peristalsis would help pull the tube further in. The diagrams on there show the tracings of the feeding tube placement. The first one is an anterior view. The second one is a sort of depth cross-section view. And then the third one you see is a lateral view. I outlined on the very tip there the red portion of each tracing, and that's where the tube is in the small bowel. The very center one shows the tube tip descending down from the stomach into the small bowel. So if I could have had 10 or 15 more centimeters, it would have been an ideal placement. We did drop the tube feeding down to 20 cc's an hour just to be cautious and make sure he didn't aspirate or have any more tube feedings rolling out. All right, so he tolerated the tube feedings over that night, and again, the pressure injuries were developing on his face. He's maxed out on his propofol. At this point, we're at day 5 of not meeting his protein needs. So we changed him to a very high protein peptide-based formula, providing 110 grams of protein, which was 1.2 grams per kilogram. As Dr. James said, after 11 days of not having a bowel movement, he starts having them. We stopped all of his laxatives except for one. We kept the Senna. The tube feeds continue at goal. He's tolerating being supine. And over the next 3 days, he continues to have more bowel movements, develops a pressure injury on his coccyx. I guess the slide there has the one on his cheek. We didn't want to show his bum to the world, so we didn't put that picture on here. Finally, we did on day 16, we did a spontaneous breathing trial, and he got extubated. We also stopped the Senna, so he no longer had any more laxatives or stool softeners. So over the next 5 days, we changed him to the standard 1.5 high fiber calorie formula in hoping to help regulate his stools. Passes the swallow eval, gets a modified diet, transitions to nocturnal feedings for a few days, and then ultimately on day 21, he gets his feeding tube removed. And he's just noted to be just extremely weak and has lost about 8 pounds so far. In hindsight, I could have kept him on a higher protein formula, but with the uncertainty and availability during the pandemic, we felt we needed to conserve those formulas for our vented patients on propofol. So he gets admitted to rehab for therapy. Initial RD assessment there, notes poor intake at dinner. He's just physically wiped out from therapy. She adds some nutrition supplements. She did perform a malnutrition severity assessment and found muscle wasting on his temporal region, clavicle, legs. There was a 20-pound weight loss overall, 10 pounds prior to admit, and then the 8 to 10 pounds during his acute care hospital stay. His pressure injuries, as you can see, are healing really well. And then day 34, he passed a video swallow study. He was eating 100%. And then finally, he got discharged home on day 40. So down to 196 pounds, but healing, doing better. So at this time, I will pass it over to Kirsten, and she will take over for the nursing standpoint.
Good afternoon. I'm going to give a general overview of my experience as nursing critical care during COVID-19, and then I'm going to end with a nursing-focused review of the case study we've been talking about. So some of the factors that necessitate a patient coming to critical care. Generally, our patients are seen needing about 6 or more liters of oxygen. That's important because therapies such as BiPAP or heated high flow were not being used because of the risk of aerosolizing COVID-19. Also important to this conference is these patients, when they either get transferred into critical care or admitted into critical care, have had very poor PO intake leading up to this admission. As Dr. Jane introduced, the MDs at our facility are choosing to rapidly intubate the patients that come to critical care, as well as place central lines, arterial lines, and at times we've been calling upon anesthesia to help with these procedures, trying to limit the exposure of our critical care doctors. At our facility, we chose to use enhanced contact droplet isolation. Negative pressure rooms were kept available for potential aerosolizing procedures. So anytime a procedure needed to be done that could potentially aerosolize COVID, they would be transferred into a negative pressure room, procedure done, an hour or two afterwards, transfer them back to their room. We were donning and doffing the typical things everybody's seen: mask, goggles or face shields. We have the lovely blue plastic gowns and gloves at our facility. Something important to point out is the IV pumps, mechanical ventilators, all tubing, all machines were kept inside the patient's rooms behind closed door. The rationale for that is that the amounts of medication that we would need to prime long IV extensions and potential wastage were going to be taxing on our limited pharmacy supplies. So as we all know, it's a critical balancing act between conserving PPE and conserving medications. And when it came to IV pumps specifically, the things that lead nurses going in and out of these rooms, we found it best to just go ahead and keep them in the rooms, conserve the medication, and use a little more PPE. Due to the rapid nature and deterioration of the COVID-19 patients house-wide and in critical care, a nutrition consult is being ordered early into hospitalization. When they come to intensive care, there's an almost immediate consult for feeding tube assessment as well as placement of a small bore feeding tube. Some RN super users, such as myself, have been trained to use the specialized equipment to try and place the small bore tube, small bowel, but of course, any RN can place either a small bore tube or a large bore tube, obtain a KUB for verification of gastric placement. At our facility, we're very lucky to have Kara Davis, who tends to place all of the small bore tubes for us. The tubes aren't just important for nutrition. There's also many medications that cannot be administered through alternative routes, hydroxychloroquine being an important one early on. In future slides, I'm going to touch on the importance of the small bowel placement a little more in the nursing management of those two. A key nursing goal when caring for critically ill ventilated patients is keeping them comfortable and compliant with the ventilator while also keeping them hemodynamically stable. My experience has been these patients are requiring large amounts of sedation, pain medication, as well as paralytics in extreme circumstances to be compliant with the ventilator. And consequently, because of these high-dose continuous medications, they're requiring vasopressors such as norepinephrine, phenylephrine to keep them hemodynamically stable. Propofol and Precedex are common drips that we use in the critical care settings in normal times. Fentanyl is something we tend to give PRN for perceived pain discomfort. But in an effort to group care and reduce exposure, reduce PPE usage, we started and continue to use continuous fentanyl drips on a pretty regular basis. So consequences of these large amounts of sedation, paralytics, and opioids. These patients are critically ill for weeks, again requiring long-term high doses of propofol, fentanyl, and paralytics at times, leading to issues, as we've already alluded to, such as constipation and vomiting. Opioid-induced constipation, again, continuous fentanyl drips. We've also gone through periods where we've tried using scheduled immediate release or extended release, OxyContin, oxycodone, hydrocodone. These patients initially present with decreased bowel sounds and peristalsis related to their critical illness. And again, I can't imagine that the long-term sedation, paralytics, and opioids don't contribute to that. But something that really kind of took me by surprise as a nurse taking care of these critically ill COVID patients is the amount of vomiting we have seen. Again, is that a consequence of long-term sedation, paralytics, opioids? Micromedics quotes that 6% to 37% of people who get fentanyl are going to experience vomiting. But a big contributor is head of bed issues. These patients, especially when they progress, are prone. So not only is their head of bed never above 30%, but they're also flipped onto their stomach. Vomiting of gastric residuals, as you heard, has been a big issue, and the importance of small bowel tube placement became pretty critical in my point of view when caring for these patients. Skin breakdown, big issue again. These patients are febrile, diaphoretic, they have copious oral secretions. We are frequently moving them, especially related to proning, which can cause friction and shear injuries, pressure injuries, and frankly leads to any and all of the various lines and tubes they have becoming easily displaced. nursing is having to verify line and tube placement very frequently, and we've experienced a huge incidence of lines and tubes needing to be replaced or reinserted due to their migration. Dr. Jane pointed that out on quite a few of those chest x-ray slides. So as a nurse, I can't help myself. One more thing about skin. Assessing for and prevention of skin breakdown has been incredibly difficult during COVID. We're rationing PPE, thus rationing and limiting the amount of people going in and out of these rooms. We're using elaborate and restrictive rotoprone beds. The patients can be proned and rotated side to side slowly for up to 6 hours. The amount of time proning is prescribed by the doctor, but 6 hours is a long time of uninterrupted proning that leads to an ability to easily or even regularly assess these patients' skin. And we all know that skin breakdown is a high priority and has a lot of oversight on the institutional level. So now I'm going to end talking about the case study. As you heard, 66-year-old male, fairly healthy, few comorbidities, nothing huge. He did, the exception is, verbalize quite a few times to me. I happened to be his primary nurse on the day he got transferred to ICU, that he had a very hyperactive gag reflex and vomiting is an issue with him at baseline. So he gets transferred to intensive care in the middle of the night. I come in at the beginning of that day. His oxygen needs are very, very high. The on-call pulmonologist asked me to call anesthesia, see if they would come up, intubate the patient, place a central line, place an arterial line, as we've practiced to try and limit the exposure of our doctors in critical care. The patient is then transferred from their room into a negative pressure room. Myself and the MD gear up in full airborne precautions, cappers, N95s, goggles, face shields, plastic gowns. We begin, we sedate the patient, we lay him flat in bed. The MD proceeds to intubate the patient, who immediately vomits, as he said he would. We place an OG very quickly, connect it to suction, stabilizes airway, gets intubated. The respiratory therapist, importantly, was not in the room for any of this. They set up a ventilator, put in the settings, left it on standby mode, again, preventing them from using PPE. And so once the patient was intubated, they were immediately connected to the vent. The MD proceeded, central line, arterial line. At that point, the MD ungarbed, left the room. The RN was still in there, applied the rest of the sterile dressings, inserted a Foley catheter. As all of this is happening, the patient is not being very compliant with the vent. His respiratory rate is high. I'm having issues oxygenating him, which quickly leads me to max him on sedation to be able to get him to ventilate, and also consequently dropped his blood pressure, requiring a little bit of norepinephrine to maintain a MAP greater than 65. Of importance to me, and maybe others, I was in that room for about 2.5 to 3 hours with the MD, also without the MD. The patient was left in the room another hour, then transferred back to their room. Next day, nutrition was started through that large bore OG that was already in place. No issues for about 2 days. And then the patient continued to deteriorate, leading to a prescription of manual proning. Our hospital's need for the use of the automatic rotoprone beds was overwhelming and led to us having to manually prone quite a few patients, which, as Dr. Jane alluded to, requires 3, 4, even 5 or 6 additional staff members to safely perform large amounts of PPE. Again, no stooling, such an issue, and vomiting when we started to prone the patient. As Kara also said, at that point, the OG was removed, a small bore feeding tube was now placed in the small bowel, and the high dose sedation, narcotics use was continued because the patient continued to respiratory deteriorate to the point of needing the proning. Day 16, first stool, finally, and no further vomiting issues. 12 days, the patient went 12 days without stooling, despite nutrition, despite the additions of laxatives. And then, miraculously, the day after he started to stool, he was extubated. So some last points that I brought up in the overview and are also pertinent to this patient. This case study experienced breakdown in his integumentary system. He was very febrile, very diaphoretic. He had lines and tubes in place anywhere from 12 to 17 days, most of which migrated out to some point and had to either be replaced or reinserted. He experienced friction, shear, and pressure injuries, mostly related to the manual proning process. The facial and the coccyx injuries were of the most prominent. Issues with the GI system, vomiting and constipation throughout the entirety of his critical care stay, which led to difficulty effectively and safely administering nutrition that he needed, as well as medication. Small bowel tube placement and proper nutrition, in my opinion as an RN, was absolutely key in every step of this patient's recovery while intensive care and also throughout his hospital stay and into rehabilitation. That's going to end my portion of this. I thank you guys so much for this time and this opportunity.
So this is Kara speaking again. We had a few more slides of the principles in COVID nutrition principles, but I think we addressed most of all of these in our presentation. And so I think for time's sake, we could go ahead and open it to some questions at this time.
All right, thank you. Thank you, Dr. Jane, Kara, and Kirsten for sharing your experience of medical and nutritional management of the critically ill COVID-19 patient. I do have a number of questions. For the sake of time, I'm going to try to group some of these questions together. One predominant question that's coming through is, did you hold tube feedings during proning?
We did not hold tube feedings during proning. We at least attempted trophic feedings throughout the proning process. Again, not just in this particular patient, but as I've mentioned before, these patients require ventilatory support for days and days and weeks, and some of them require proning support for weeks. We've had some patients who've been on rotoprone beds for up to 3 weeks, and obviously we cannot ignore their nutritional requirements during this period of time. We do eventually get a handle on the GI disturbances, and we do attempt to achieve goal feeding on these patients.
All right. Another common question is, did you provide separate IV micronutrients?
Outside of replacement of measured electrolytes that were deficient, such as phosphorus, magnesium, not really. The micronutrients within the tube feed formulas were the ones that were obviously continued, and we did not add, for example, zinc or anything else to the tube feed formulas.
Okay, and the Aspen SCCM and Aspen COVID nutrition guidelines, they suggest early use of parenteral nutrition and avoidance of small bowel feeding secondary to that risk of infection of the healthcare practitioner. But small bowel feedings work for your case study patient. Can you comment on your thoughts regarding the guideline recommendation to go to PN right away?
So as experienced dietitians, you're all aware that enteral nutrition is the preferred route for all patients, and including critical care patients. We believe that with small bowel feedings, we can safely feed these patients and manage the GI issues concerns such as the vomiting and the constipation with perhaps use of peristaltic agents, and with careful monitoring of the position of these tubes. We feel parenteral nutrition is inferior and in some cases deleterious. As I mentioned in my talk, tocilizumab, which is a particular anti-IL-6 that was used extensively early on during this pandemic and was used in this patient, has been associated with very severe resistant infections subsequently in this patient population. Obviously, placing these patients on parenteral nutrition further increases their infection risk. Furthermore, as we have gotten more, shall I say, comfortable with the management of COVID-19 patients in the intensive care units, we are more confident in our ability to keep our healthcare personnel safe and to use appropriate and judicious amounts of PPE while still providing, guideline-directed care to these patients. So in our institution, we have rarely used parenteral nutrition in the COVID-19 population, if at all.
I can't recall of using it at all in a COVID-19 patient.
Neither can I.
All right. Dr. Jane, does it appear that permanent organ damage is occurring as a result of COVID-19, such as lung, kidney, or GI damage?
Yes, certainly. I think this is a systemic disease. And just like any other severe systemic disease or patient with ARDS and multi-organ dysfunction, these patients do have consequences. The lung is an obvious one, but the kidneys and the liver are also affected. And I think the jury is still out as to the long-term consequences of this disease. I think I can speak to the pulmonary aspects of this disease, and like any other ARDS, I think there may be as long as a 6-month recovery before these patients return to their baseline lung functions. As to the kidney and liver, I think the jury's still out. I don't think we really understand what this disease is doing or what this virus is doing to other organ systems and how sustained that damage may be.
Right, thank you. So Kirsten, the nurse is the healthcare provider who's consistently with the patient. What does that mean in terms of driving nutrition care?
Well, as I mentioned, I think first and foremost is always making sure the tube is in the correct place. Migration of these in any tubes has been a huge issue, even though I like to think we are very on top of that. Oftentimes, I think the nurse drives the communication with the dietitian as to what we're seeing with the patient. Not just hemodynamically, but also with the multitude of GI issues that we've seen. So I think one of the priorities of a nurse in terms of nutrition is the communication, not just with the pulmonologist or the consulting physicians, but with dietary on issues we've seen with either that patient or another patient, and modifications that can be made that we are not aware of, but dietary is very aware of. So again, I would say that a nurse's driving force behind this is more so the ability to communicate what we are seeing day to day, hour to hour at the bedside in the room with the patient, and then consulting the professionals on ways we can mitigate some of these negative GI issues we've seen.
All right, well, thank you. I have many, many more questions, but unfortunately we are out of time. So I'd like to thank you, Dr. Jane, Karen, Kirsten, and all healthcare providers striving to give the best possible patient care during these challenging days. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice, and enjoy the rest of your day, and please be safe.